Hello and welcome everyone. Today we'll be discussing a very difficult topic, that is prolonged weaning. We'll try to break it down into very small parts so that it is easy for someone to understand. So we will discuss everything as to who, what, when and how to go about prolonged weaning. Now, what is the importance of weaning from mechanical ventilation? About 3% of hospital admissions, they require some kind of a ventilatory support. Weaning is not just for ICU doctors. Patient will often be on wards after weaning. So all doctors who are involved in any kind of a patient care must have some idea regarding weaning, because they may come from ICU to the ward with prior history of weaning. So prolonged ventilation, that is a long period of time on mechanical ventilatory support, increases the risk of ventilator associated pneumonia, which as such is associated with higher mortality, long-term weaning failure, that is, it is associated with poor outcomes, and obviously if a patient stays longer in the hospital, there will be higher costs. So what is the classification? This is the 2005 international consensus of how we classify weaning as of now. The first one is group 1, which is called simple weaning. It is most of the patients, that is, you wean and extubate successfully on the first attempt. This is extremely common in the ICUs, but it's still around 60% of the cases. So every 3 patients, 2 will be like this, who will be planned for extubation and will be weaned and immediately extubated on the first attempt. However, every time we will not be that lucky. We will face some difficulty. This is group 2. They fail the first attempt and need up to 3 spontaneous breathing trial or up to 7 days from the first SBT to succeed. So SBT means the first time we are giving the weaning trial or the spontaneous breathing trial. So if the patient requires at least 3 SBTs or at least 7 days from the first SBT, then it is called a difficult weaning. So it is around 10% of the cases. Next, you have prolonged weaning, which is group 3, where you fail more than 3 SBTs and take more than 7 days to wean the patient off ventilator. Again, around 10% of the cases. So there is a sub-classification which was done in the WIND study, where you have the prolonged weaning again divided into 3A and 3B. 3A is prolonged weaning, but eventually successful, that is more than 7 days after the first attempt, and 3B, prolonged weaning without any success. So 3A is eventually we are successful, 3B is we are failing and we are probably going into tracheostomy. Now, how is the WINCEF data regarding weaning process? This was a large study of around 6,000 patients of over 50 countries. Let's see what they found out. They found that as we saw, the group 1, that is less than 1 day the patient is weaned, is around 65%. So this is the rough rate. 2 to 6 days is required in around 10%, that is the difficult weaning. More than 6 days is 10%. Now weaning failure, that is we are totally failing to wean these patients and going into tracheostomy, is around 15%. So what exactly is this failure? How do we define that the patient has failed weaning? So after the endotracheal intubation, failed SBT, the need for reintubation after an extubation, or there is death within 24 hours of extubation, these are called weaning failure. After prolonged weaning, if death occurs before hospital discharge, if there is a need for ventilatory support after discharge, all these can be seen as failures of weaning. So what exactly is weaning and how do we do it in our ICUs? Weaning process has 4 key steps. These are similar for all patients and they must be remembered. The first is that treat the underlying cause of respiratory failure. The reason for which the patient has been admitted to the ICU and on ventilatory support must be treated or sufficiently recovered enough for me to start the trial of weaning. For example, if the patient has pneumonia, then it has lessened to a certain extent that I know clinically or with whatever method I am using, that my lung has shown some signs of recovery. Next is assess the readiness to wean. Once I have seen that my disease process is partially recovered, I will have to see whether the patient is ready to be weaned. This has to be done on a daily basis. Next, we test the response to reduced support, or what we call as the spontaneous breathing trial. And finally, extubation or decannulation, that is liberation from the ventilator. So how do we assess readiness to wean and why it is crucial? Delayed weaning increases the mortality and ICU stay, so we should be very proactive in these cases. Many patients are able to wean earlier than the doctors expect, which is reflected in the fact that 50% of the self-extubations that we see in our ICUs do not result in re-intubations. Daily readiness checks predicts the higher weaning success. Practice vary widely. Some ICUs assess daily, others less frequently. So it is not something which is standard and followed in all ICUs. So what should we check, if at all we are checking on a daily basis? The first is the clinical check, the overall clinical status of the patient. If the patient is having a good cough reflex, able to clear his or her secretions, no excessive secretion is coming, acute illness has improved the reason for the ICU admission. Next is the objective criteria. Now, there are no such absolute rules about these criteria, and not that all criteria need to be fulfilled. There is still a lot of research which needs to be done in these things, but then overall we know that most of these are useful indicators of a weaning trial. We must make sure that the heart rate is less than 140, the blood pressure is stable, the systolic around 90 to 160 with minimal vasopressor support. Regarding oxygenation, the saturation is more than 90 with FiO2 less than 0.4, or the PF ratio is around 150. PEEP is less than or equal to 8. Regarding the lung function, the respiratory rate is less than or equal to 35. Maximum inspiratory pressure is minus 20 to minus 25, not more than that. Tidal volume more than 5 ml per kg with a vital capacity of more than 10 ml per kg. Rapid shallow breathing index has to be less, and it has to be lower than 105. Other things that you should look for is significant metabolic or respiratory acidosis, patient being awake, normal temperatures, no major hyper or hypoglycemia, no major electrolyte imbalance, especially potassium, magnesium and phosphate, and a hemoglobin level 7 or more than 7. The clinical note is, mind you, these are all guides. Don't take these values very seriously, please. These are not strict cutoffs. You can manipulate these values patient to patient, person to person, and based on the individual's and the clinician's judgment, you can decide to go about weaning. So it's not necessarily you have to meet each and every criteria, then only you will go for weaning. But these are good indicators. The next would be ultrasound. This is not something which is currently still being used very properly for weaning purposes, and should be used regularly, because a lot of things we can learn, like diaphragmatic weakness. It can help finding out the diaphragm movement and its thickness. Promising tool, but techniques vary, not yet standard practice everywhere. Regarding spontaneous breathing trial, why do we do this? We do this to see if the patient can breathe without the full ventilatory support. So we reduce the ventilatory support, right? So how do we do it? To do it, we reduce the pressure support to 5 to 10. You can also reduce it to 0. It's not a big problem with that. The fact that the tube is going to add a lot of resistance is a fact, but then keeping it 0 is also feasible. It's not that it is anti-physiological or something. This can be done, but mostly what we practice is around 5 to 10 of pressure support. Regarding TPs, you can also keep TPs. No need to have a battle on this, whether we should go for pressure support or TPs. It's a very individualistic thing, and none of the studies have shown any major discrepancies or very gross difference between the two methods that there has to be a major debate on this. It's based on individual practice, your nurse's comfort level, your doctor's comfort level. If you're comfortable with either, you can choose any one you want. Regarding the duration, it is usually given for 30 to 120 minutes. Again, not something which is a clear cutoff. If the patient is very good and a very simple weaning, you can do it within 30 minutes. If it has been done for a long period of time or there are some risk factors, you can do it for 120 minutes. What exactly will count as a failure is your oxygenation going down, your PCO2 going high, your RR going high, that is the respiratory rate, your heart rate is increasing, or there are arrhythmias, you are getting an hypotension, the patient getting agitated, confused, or the work of breathing is increasing. What is important over here is the person who is actually looking at the SBT must make sure that if there is a failure of the SBT, he or she documents the fact that these factors were the reason for which I have terminated the SBT. Without this, it is very difficult to direct your treatment to a particular direction. So if you are having confusion and rising CO2, it must be documented as the reasons for this failing of the SBT. Now the most important tip over here is while everything is to be done, do ask the patient how they are feeling. If they are feeling good, then there is a very high likelihood that the extubation is going to be successful. If the patient is not feeling very good and they are feeling some distress, then probably the SBT is not going to be a success. So which SBT method is better? As I have said, there is no major difference, so no need to really do any battle over this. Some data suggests that 30 minutes of pressor support may lead to more successful extubation and lower mortality, but then the results aren't strong enough for an unnecessary debate on this. We can choose anyone, as I said, based on your own staff's experience, preference, comfort level. So unnecessary debate on this. Regarding successful SBT, then if the SBT is a success, the next step would be extubation, which is very obvious. Some studies show reconnecting the ventilator for 1 hour after SBT may reduce reintubation risk, but this is not a very standard practice. This is something which has been done in a couple of trials, not really required. Avoid SIMB for weaning because it is linked with worse outcomes. SIMB could be done in very difficult weaning cases where I am using this as a method prior to the day I am planning extubation. So maybe 2-3 days before I am extubating, I am putting on SIMB is feasible, but not on the day where I am actually giving the SBT trial for extubation. Next step, as we have seen, either I am failing the SBT, going back to the whole process all over again, or I am going ahead with extubation. If I am going ahead with extubation, how do I do it? What is extubation exactly? This is the final step in our weaning process where I am removing the endotracheal tube, as simple as that. Now, it has to be done after a successful SBT, provided I don't have any new contraindications. Now, what are the contraindications? These are very important. Do not proceed if any of this is present. Onset of an acute phase of illness that requires intubation. For example, the oxygenation is going down, you are seeing the RR is high, the ARDS is unresolved, the pressures which were slightly low are not so after the SBT has been given. So you still feel that the patient is still in an acute phase of the illness. So don't go for extubation. Poor neurological status, the GCS is not very bright. It's not that the patient will every time be fully awake. This patient is very borderline with a GCS of around 7 and 8. So you're not very sure regarding the extubation, whether I should go for the extubation or not. It's better to avoid in these cases. Next is secretions. You see that there is a lot of secretions coming out suddenly. It's better to wait in this particular case. Or you find some kind of an airway obstruction, the patient is failing the leak test and all, so you feel that there is an obstruction of the airway. Or there is a new onset shock, arrhythmia, then better to avoid it. These are contraindications. Or if there is some residual neuromuscular blockade, then better not to go for extubation. The point you should note is poor cough and excessive secretions. These are something which are needed to be seen. The other things you will be very easily getting an idea about, because a poor neurological status, a shock state, or a worsening respiratory acute condition will be very easily visible. What we miss are the poor cough and excessive secretions. These things must be looked into. Until and unless you look into for every patient, you will miss this thing. So keep in mind that these things are the most important risk factors for extubation failure, and you should specifically look for these. Only then you will be able to successfully extubate the patients. Next is upper airway obstruction, where I have already said you do the air leak test. It is the deflated cuff. If the air passes around the tube, then you can say that yeah, the patient is good for extubation. I'm not going into details of the calculations of that. Regarding what steps we need to know and do before the extubation. Again, reassess the contraindications. This is very important. Next, prepare for reintubation. Make sure that your equipments are ready. The patient can be reintubated even after 5 minutes also. So be completely prepared. Position the patient upright in a sitting position. This is the best position to extubate. Don't extubate in sitting positions. Suction, especially of the oral cavity, should be done. Finally, the step-by-step technique of extubation. Ask the patient to take a deep breath. Next, as the patient exhales, the patient is exhaling from that deep breath, deflate the cuff so that if there is any secretions around the cuff, it will be pushed out. Remove the tube smoothly. Don't do it very slow process. It actually causes more pain to the patient. It has to be a very smooth and quick action. Don't give a lot of stimulus to the patient during this period. Immediately do an oral suctioning, which is very important. Don't try to suction the airway directly. It will be enough if you just suction the oral cavity. That should be more than enough. Encourage the patient to cough and bring the secretions to the mouth and then do the suctioning. And then you can do a physiotherapy. That would be more than enough, chest physio. Now, after extubation, provide supplemental oxygen if required, but then it is general practice to give some oxygen for at least 1 hour, 2 hours. That is more than enough. Now, next would be very important. Monitor closely for several hours. This is critical and very important. Be prepared for frequent suctioning. Watch for signs of airway compromise, especially obstruction like stridor, desaturation, increased walk-off breathing, increased heart rate, increased respiratory rate, new arrhythmias, new shocks, everything. So next task would be to preventing post-extubation respiratory failure or the PERF. This is very, very important. What is the definition? PERF means the need for reintubation within 7 days after the extubation. It carries much higher mortality than successful extubation. The common causes being excessive airway secretion. As I've said, this is something which you should look for every time you go for an extubation. This is the most critical thing, and this is something which we clearly miss many, many times. The fatigue of the patient, weak respiratory muscles, fluid overload. These must be kept in mind. The risk factors being age more than 65, a pre-existing left ventricular dysfunction, anemia, high Apache 2 score, and long duration of mechanical ventilation. Please remember these risk factors. They are very, very, very important. In these cases, you must be extra cautious and be always looking for signs of respiratory compromise or new distress so that you don't drag this patient too long before reintubating them. They being the age, pre-existing left ventricular dysfunction, anemia, a high Apache 2 score that is on admission, and a long duration of mechanical ventilation. Exactly, don't go for any cutoffs. The overall thing being present is more important than going for values of cutoffs like Apache 25 or anemia of 7 or something like that. Don't go for those things. Look at the overall picture. If most of the things are going in a high risk zone, be very, very careful. Anything more than 1 over here is a significant risk factor of PERF. General prevention principles being identify the high risk patients early. This is very critical. Regularly monitor after extubation. First hours to days are very, very important. Support breathing with breathing therapies where needed. We will come into what are these breathing therapies. They being the NIV. This is very important. If you feel that there is some kind of distress the patient is in, always go for a non-invasive ventilatory support. They are very important and very good, and there is evidence that it is going to be of benefit, especially in patients who are difficult to wean, and of course in patients who have a heart problem or COPD. So we already know in these cases that it is going to be beneficial. Regarding studies showing that there is shorter time to mechanical ventilation, shorter ICU stay, lower incidence of VAP and higher weaning success. So post extubation NIV in high risk patients with these conditions is very important. We have mixed results in general ICU. If they belong to these three groups, then it is very helpful. But if you are doing it general for all patients, there is no improvement in mortality or time to liberation. But then it is not expected. It is for a very specific group and not for everyone. It may help reduce the ventilator days and ICU stay. Hospital mortality, VAP rates, ICU length of stay improved in most patients if they had a chronic disorder, which we are saying is very important. If the patient has a COPD, a heart failure, and a prolonged extubation time or weaning period, then going for NIV is very important. In non-COPD should be applied only in experience center with clear protocols. So don't make a rule that apply on everyone. If these three conditions are not there, then you have to be really thinking about it. Now, why it has been written that it is experience center record? Because many of the times what happens is people just extubate onto an NIV and they think that it is something which will cover everything that is. No, it's not going to cover everything. It is going to cover only if you have a COPD, only if you have a heart failure, especially left ventricular failure, or if there is a prolonged weaning process it has been done through. If any other condition is there, then it is not going to help. It is not going to help in a case of low GCS. Please understand this. This is where the problem which we are facing is that people are extubating low GCS patient and putting on NIV and then think that the NIV is going to help. No, how it is going to help? It is not going to help. If the patient is requiring a prolonged NIV and the GCS is still low, probably you should re-intubate early. That is why you need experience centers. You can't just keep anyone and just put them on NIV, because in that case you are delaying the intubation, thereby increasing the mortality. Next is HFNC, again a very important thing that should be used, not for all cases. Do not go for these studies. They are not been done in a very good population. So what we know for sure is it can be used in place of NIV, but then I would suggest it is better to go for NIV rather than for HFNC. HFNC is for a very specific subset where you have a very high oxygen requirement, and only that case it is going to be of beneficial. Otherwise, it is better to go for NIV. If tolerance is an issue, you can try with HFNC, but it is definitely not a replacement for NIV. No way it is a replacement for NIV, especially in post-extubation status. If it is a post-extubation station, patient is having some challenge regarding the comfort level, HFNC is of benefit. But you have to be very cautious over here, monitor the patient very closely, because no need to delay the intubations where it is required. Regarding the practical bedside approach, first step is identify the high risks. Plan extubation to a bridge therapy is preferably NIV in high risk specific population group, and monitor closely for early signs of failure. Do not wait and do not drag the patient endlessly on these bridges before you are reintubating. Escalate support promptly if there is any kind of a deterioration. Regarding pathophysiology of difficult and prolonged weaning, what exactly is happening in these cases that they are finding these problems? So why it actually matters, why we need to know about this pathophysiology? It matters because the longer time on mechanical ventilation is associated with both outcome and cost. 50% of the patients with weaning failure stay ventilator dependent for 1 year. That's a huge number of time. So 1 year mortality in these cases can be as high as 75%. Even if successfully weaned over a long course, 42% may need ventilation again. This is very important. Many of the times we just wean the patient after a prolonged stay and send them home being very happy that, oh, we have done a great job and we have successfully weaned a patient. But no, they end up on ventilator support. Almost 50% of the patient end up in ventilator support. It's not a small number that should be neglected. This has to be kept in mind when you're keeping a patient for a prolonged weaning and prolonged difficult weaning process. The cost of care escalates. This is very important. The cost of care has to be kept in mind. You are escalating the cost, and the patient has to pay for it. Whoever is paying for it, the insurance or whatever, is going to have an impact on that. So keep your budgets in control. About 20% of the ventilated patients are difficult to wean, so it's a small group but high complex and costs. So in this particular difficult to wean group, though it's a very small group, you have to be very understanding about the complexity and the cost involved with it. It's going to take a long time, it is going to cost a lot, and even after my best outcome, that is weaning the patient off, I may in 50% of the cases go back on ventilatory support. So everything must be kept in mind when you are using your resources, when you are using antibiotics or escalating the cost of this patient, to understand every aspect over here. Now, why this tripod? There are three main factors for adequate breathing. So any one of the leg breaking down, we will be unable to breathe. So what are these tripods? So weaning failure is because when the balance with the three things, that is the respiratory muscle load, the respiratory capacity and the respiratory drive, these three things have to be disturbed. Any one getting disturbed will result in prolonged weaning. So as you can see, any one leg being weak means that you cannot sit over here. You are going to collapse. So the breathing will collapse if any one, that is the muscle load or the capacity or the drive, any one is affected. So we'll come first to the muscle load, that is how hard the muscles have to work. This is the resistive load, this is resistance in the airways, how strongly your diaphragm and the intercostal muscles are contracting. This is excessive secretions, bronchospasms, which increase the work of breathing. For a COPD patient with a mucus plug, more effort is required to push the air out. Elastic load, that is stiffness of the lung, that is the chest wall is stiff, there is pleural effusion or the lungs are bad. Causes being atelectasis, pulmonary fibrosis, lung edema, chest wall restrictions, threshold, that is load extra pressure needed before the airflow starts. So this is very important. You need to generate a higher pressure before the airflow is starting. So this is increasing the work on the muscles. Finally, the cause for these are the gas trapping, that is intrinsic PEEP. So the pressure has to be overcome before you can get the expiration started. Now, respiratory muscle capacity, that was the load, how much work it is able to do. Now, what is the capacity of this muscle to work? The inspiratory muscles, they don't have endless strength and endurance. They have their limitations. The common causes why there is low capacity in the ICU are critical illness, neuromyopathy, common in the ICUs, electrolyte imbalances, your potassium, magnesium, phosphate, everything is low. So the contraction is difficult. Prolonged immobilization, the reason why the patient was having prolonged weaning, the patient is in the ICU for almost 2-3 weeks. So that's a prolonged immobilization, or that will make the capacity less. Finally, the drive. There must be a drive coming in that the breathing will start. This is mainly the problem in the brain. So the pathway is mainly medulla, spinal cord, respiratory muscles. So any defect anywhere will cause problems. Like at the brain level, there can be sedation, opioids, anti-epileptics, or there can be a new brain injury, there can be a stroke, there can be some demyelinating lesions, some tumor, anything can happen. Next is metabolic, like metabolic alkalosis. You have so much alkalosis, that is, we make the patients negative fluid balance using loop diuretics, they become very alkalotic. So the drive for the chemical stimulus for drive is gone. Nerve levels, so you have some kind of a nerve injury, especially at the higher cervical or phrenic nerve. Neuromuscular junction can also be affected. The use of muscle relaxants, aminoglycosides, all these can impact your muscle contraction. So the practical ICU application is that when a patient is failing to wean, check these three things. Check for the load. Is the lung too stiff? Is the chest wall too stiff? Is there a airway obstruction? Check capacity, the electrolytes, the muscle strength, the deconditioning. Drive, check for sedation, neurological injuries, metabolic issues, anything can happen. Now, what are the management strategies that we have? How do we look for this? Prolonged weaning is a complex, resource intensive process. This is something which I am emphasizing again and again, and this intensive process will be associated with mortality, morbidity, cost, and prognosis implications. The success rate is around 65%, where eventually we get the patient off ventilator. The best outcome in specialized weaning units is that it focuses on cheaper care and more focused care. The main problem that we face is there is a misconception that if I spend a lot of money, I'm going to get the patient out of ventilator. Not necessarily. Every unit that is specialized always looks for cost cutting and gives the best outcome with least wastage of resources. That has to be kept in mind for everyone. It requires a multidisciplinary team of doctors, nurses, respiratory therapists, physiotherapists, nutritionists, psychologists. Everyone needs to be there. The problem is, many of the times when you think of multidisciplinary team, we just think a team of doctors like nephrologists, neurologists, intensivists, cardiologists. No, just one doctor is more than enough. The other team members must be important, like nurses, the use of respiratory therapists, physiotherapists, nutritionists, psychologists. They're more important. Not a 10 panel of doctor is going to make the patient come out of ventilator. No, that's not going to happen. You have to be including other team members who are not doctors. Predicting weaning success, harder to predict than in simple weaning. This is very difficult actually, how to whether we can predict that the patient who is going to get off ventilator. SBT success does not guarantee extubation success, mind you that. ICU severity scores are again poor predictors of extubation success. Failure to tolerate early pressure support ventilation for more than 24 hours, there is 2-time likelihood that the ventilation is going to be more than 7 days. 3-time higher ICU mortality, and low pre-weaning arterial pH is a risk factor for failure. Again, these are all speculations. We don't know much. We need more intensive work on these things, where how we can predict that weaning is going to take how long and the prognostic implications on mortality and extubation. Tracheostomy management is important. Consider if you are unable to wean from endotracheal tube. Physiological benefits is better tidal volume, stronger pressures, lower airway resistance. Timing is controversial. We're not going to the controversy. Say around 2 weeks, 10 to 14 days. Early is within 10 to 21 days. It varies from literature. Many units do it within 14 days. That is the standard for most of the ICU. So we're not going to details of whether we should do it at 10 or 21. It's a very individualistic practice. It depends on your setup, your infection rates, how good your nurses are, how better care they can give. So early tracheostomy may have some benefits, but then it's not something a very concrete evidence that we will recommend early tracheostomy in many cases. It all depends on your individual ICU's protocols. Decannulation process is important. Downsize the tube, pressure support ventilation, gradually increase the cuff deflation periods, and then you can go for a one-way speaking valve and finally cuffless, and then probably decannulate. It may not require all these processes. You can go skip some process as well, like one-way speaking valve can be skipped, and all this process can be done over 24 to 48 hours. Regarding minimizing the risk of VAP, VAP prolongs weaning and increases the mortality. The key prevention measures are preventing the PERF. Consider early tracheostomy, subglottic secretions, semi-recumbent position, minimize the sedation, oral care with chlorhexidine mechanical cleaning. Nowadays, we are recommending mechanical cleaning. Chlorhexidine is no more being used for oral care in our ICUs. And use of respiratory physiotherapy to clear the secretions. So again, most of the things are speculative, not clear-cut evidence-based. You can use anyone as per your ICU's protocols. Nothing's optimal to really send. Regarding nutrition, this is very important. We do know that nutrition has to be optimized. Adequate early feeding is very important in these cases. Permissive overfeeding may lower in-hospital mortality in some cases, especially when there is acute illness. In the initial acute phases, you can go for permissive underfeeding, but then once you see that the patient is off that acute phase, you have to escalate your feeding, especially the protein part. Optimize stress elements, especially magnesium, which helps the muscle function. Physical rehabilitation is very critical over here. ICU patients lose muscle mass. Critical illness weakness is common, especially where there is prolonged weaning. So rehabilitation is important because it improves strength and weaning success. Multimodal rehab is very important. shorter ventilation times, higher success rate, intensive physiotherapy, higher weaning success, inspiratory muscle training is required, and no negative effects, and it should be done routinely in all ICUs, especially if the patient is more than 4 days on ventilatory support. Psychological support is something which is often neglected, but you must understand the patient is gradually getting off ventilator, his acute illness is decreasing, so he is anxious, he has a fear, he's delirious, he doesn't see his family members, he's on a ventilatory support, he doesn't know what is happening. So this is very important. You have to allay the anxiety, reduce the fear. Poor psychological health over here is going to make it very difficult to wean these patients. Limited evidence of formal intervention, but then what intervention exactly, how to do it is not something which can be replicated at bedside. So clinical psychologist involvement will definitely help over here. Feedback techniques historically has shown some benefit. So whatever technique you are using, please use some technique, because the patient is anxious and fearful. So you have to allay the anxiety and reduce the fear. So the practical approach is identify early whether there is going to be a failure, that is high pressure support requirement or low pH, optimize the physiology, treat the lung condition, manage the load, capacity, drive balance, tracheostomy early enough if the patient is not showing any signs of progress, aggressive VAP prevention, tailor your nutrition, and daily physiotherapy and inspiratory muscle training, and do address the psychological needs. Communication, reassurance, relaxation, everything is important. So this is the multidisciplinary team as we have discussed. The physician is one of the aspects. Apart from that, you need nurses, physiotherapists, dietitian, speech therapists, very important, psychologists, technicians, pharmacists, occupation therapists. So the chest physiotherapy, optimizing nutrition, physical rehab, psychological support, minimizing sedation, tracheostomy, all will help you in prolonged weaning. So what are the challenges that we face? Currently, there are a lot of knowledge gap. Better early predictors are required, because we still don't know who is requiring this difficult to wean. Diaphragm ultrasound is promising, but still needs large scale validation. NIV outside COPD and heart failure needs to be studied. HFNC again can be effective, comfort and cost benefit needs to be seen in preventing PERFs. Tracheostomy timing is still unclear, so best time would be whatever you think. Physical rehab, psychological support are very critical. Poor sleep quality in prolonged ventilation patient is common, so its effect must be very well understood, and we need more studies on that. Improving the sleep quality is vital. AI and machine learning can help in predicting the readiness to wean, but current evidence is limited, so the results are extremely unclear. So to summarize, weaning is central to managing patient with respiratory failure. So we classify it as simple, that is weaned on first attempt, difficult, less than 3 attempts or within 7 days, prolonged, more than 7 days, more than 3 attempts. Early daily readiness check is important, early initiation when possible. This will result better outcomes. NIV in extubation in COPD patients, other conditions, be cautious. HFNC again only for comfort. Regarding the pathophysiology, we have discussed the 3 things: the muscle load, the muscle capacity and the muscle drive. And finally, management is multidisciplinary, addressing all the contributory factors. Thank you for your patience.